I've been given this title of Psychological Aspects of Survivorship, which was quite a broad area. So let's see what I've come up with. So in terms of presentation plan, yeah, first of all, size of the problem. And then, can you hear me okay? Is that okay? Yes, and I'm aware I do have an accent, so if there's, yeah. So yes, please stop me if I cannot make myself clear. Yes, so covering psychological consequences of cardiac arrest, I've broken it down into different areas. So first of all, there is a pathological process that caused the cardiac arrest. That's important too. The post-intensive care syndrome really depends how long you spent in intensive care, but the longer and the more likely it is that there will be issues related to the stay in intensive care. Hypoxic ischemic brain injury, which can happen, is not always spotted, and it's not always the biggest problem, but it may be there, and may be another factor to take into account. Then a little bit of section on the forgotten patient. We'll get back to that. And then, yes, what the current pathway is, therapeutic interventions offered now, or could be offered in the future, and future developments. Right, you'll probably come across this number, but basically there are around 30,000 individuals that were treated in 2014, and you're aware with the percentage of survival, which is quite low. It's about 8% in the UK. So these 30,000 people are 53 for every 100,000, which is not a negligible number. Numbers are similar across the world. In terms of survival, probably a bit lower in Asia, 3%, but we're hovering around 8, 7, 9, 10. I mean, these numbers are not great. So yes, there are very poor outcomes. They have remained mostly static in the past 3 decades, but some cities have done much better. I think London is around 13%, and other areas around the country some are more virtuous and some other less so. But I think it's important to stress that increasing just by a few digits, from single digit into double digits, will mean probably more than 1,000 lives saved every year. So little changes could be really significant. You're probably familiar with the chain of survival. It strikes me because the first 3 steps, probably for the vast majority of people, happen in around an hour at most, although the vast majority probably 15 to 30 minutes. So need to spot what's happening, perform CPR, if you shock, and then the 4th step is actually, it involves so many different things. What happens in hospital, what happens after. So it's difficult to give it a time frame. It could be a few days, a few weeks, a few months, a few years. So it probably needs to be broken down into different steps actually. So I'll digress a little bit here, but it's good that with regard to the first 3 steps, so we are moving forward. I'm really pleased to hear that CPR will be taught to every secondary school pupil from next year, which is absolutely great. And also that the defibrillators are available everywhere, and if you work in the field, you spot them everywhere. You can never ever go to a place without looking out to see whether there is a defibrillator. And this summer I was actually going to visit my wife's family in the very south of Italy, which is a pretty rural area. I think there are about 2,500 people living there. And this time I was welcomed by this, which it was the first. I've been there a few times. I don't think this is actually a real word, but what it means is it's heart protected, and sure enough, there was a defibrillator there. So it's pretty rural. I'm not sure anyone really knows what it is and what it should be used for, but it was there. So one element of the chain is in place. Education and everything else needs to come later, but it was a good start. So as I was saying, the causes of the cardiac arrest are really important. Most people, most of you, I bet, will have had a presumed or confirmed cardiac etiology. Why is this important? Because obviously, if somebody has had a cardiac arrest because of another reason, because of near drowning, because of trauma with bleeding, lots of blood loss, drug overdose, a septic shock, or epilepsy. So the trauma, it's kind of different. There is another reason why it was triggered, and there's something else that if somebody comes to me with some distress, I need to take into account. But I'm well aware that in the vast majority of cases, people that have been reached by emergency crews and where resuscitation has been deemed possible have had a cardiac cause. But this is something else I think it's important to remember. So I've pulled this off the NHS website because in terms of dealing with the consequences psychologically of a cardiac arrest, I started off with what happens after a heart attack, because I think a cardiac arrest is heart attack plus. So obviously, find out the causes, if possible, diagnosis, treatment. Really important bit is cardiac rehabilitation, which I think is really important as a first way to start dealing with the problem and understanding and kind of normalizing all the things that come after having had a heart problem. But obviously, and unfortunately, not everyone is eligible. And that's sometimes a real barrier. And then there are a number of things that need to happen for people to return to a good quality of life. Life may be different, but life may be just as good, or in some cases even better. But we're talking about return to exercise, return to work. These are questions that people have in mind. Is it possible to return to driving, return to having a sexual relationship? What about mood after? And then all the behavioral changes that may need to be put in place. So diet, do I need to change my diet? Is smoking something that I can stop, can quit? Alcohol, weight management, regular physical activity, all these things need to be taken into account, medication, etc. So this is what happens and what people have to deal with after a cardiac arrest, heart attack and as well a cardiac arrest. In addition, in a cardiac arrest, we've got the cardiac arrest syndrome. So the body takes a big hit. Sometimes it's much bigger because there can be all the manifestation of there was no blood flowing through the body. So this causes global problems, shock, multi-organ failures, neurological damage, so a much bigger hit. Post-intensive care syndrome, so weakness, fatigue, problems with mobility initially, because every day you spend in intensive care, there is muscle wastage, and then it takes a bit longer to build up the strength. Problems with sleep, I found out, are quite common after a cardiac arrest as well. Cognitive issues, usually mild, sometimes a bit more moderate, poor concentration. And as you can see here, we talk about the patient, but we talk about family as well. And during this presentation, I'd like to give a bigger role to family because it's a real systemic problem. Every time there is a big event that happens, family is also involved and family takes a big hit as well. So there is a psychological side of things that affect family as well, with some PTSD, which is post-traumatic stress disorder symptoms, which are you may have heard about it, but the flashbacks, the poor sleep, the kind of depressed and anxious mood. That is not terribly uncommon after such a sudden, unexpected event. And then there's something very specific to to cardiac arrest, which anxiety and depression and post-traumatic stress, very specific to cardiac arrest. There have been a number of studies, and as often, what the answer you get depends on the question you ask. So, even in the most conservative study, though, at least 14% of people, which is roughly 1 out of 7, did have clinically significant, which means, talking down to earth, that it affects your life, levels of anxiety and PTSD symptoms, which is basically what may stop you from going about doing your business every day because of anxiety. But it can be as high as 65%. It really depends how we look at it and what instruments we use to measure it. And quite interestingly, participation in everyday life and return to work were applicable, because at least in our center, the average age after a cardiac arrest is around 61, 62 years. So it's right there where people are kind of wrapping up. But people are much younger, people in 30s, 20s, 30s, and 70s, 80s. But where applicable, after a cardiac arrest, people return to work less than other people who have had a heart attack. And we want to understand whether that's a choice or whether but there's factors that can be modified. If you've had an ICD, there are additional ICD put in place, additional factors to take into account. And they're all interconnected. So obviously, the thoughts of mortality and the change in self-image, they're quite common anyway, whether you have had an ICD or not. But appearance concerns, and then the healthcare relationships, because you need to come back and have frequent checks. So there's always a link to the hospital, always a reminder. Impact on family, especially if work has been affected. So if you work in a workplace where there are radio frequencies involved, there might be issues. I'm not quite sure whether that's the case, but I've had people coming back to me saying, I don't know whether I can go back to work because of this and that. Obviously, this together with fears of shocks, fears of shocking other people, has an impact on family, has an impact on the whole system. During a cardiac arrest, there is no blood flow, and if you're interested in these sort of numbers, basically, it looks like people lose consciousness about 20 seconds after a cardiac arrest, and then kind of the brain goes into a coma-like level of functioning quite quickly. And the brain is very hungry for blood and oxygen and all the nutrients, so problems start occurring within minutes. And usually minutes is what we have got to actually address the problem and start fixing it. And then even when we restart the heart, there are problems with regard to the return of blood flowing. But this is just to say that there are some perturbations to the brain, and although they may not be very well evident, they might still be there. Thing is, the vast majority of people who survive, wake up and leave hospital, don't have severe brain injury. So it's less than 10%. Obviously there is the 10%, but I think it's also important to focus on the other 90%. Of these only, half, about 50% experience some mild to moderate cognitive problems. That's my experience as well, having seen a few dozens of people. It's usually mild. Sometimes it can be moderate, but the type of impact it has on day-to-day life ranges a lot, whether young and working or not young and having a less active life, for instance. The most common problems are with memory, because that's what people tend to notice anyway. And then we call them executive function. It's a bit of an umbrella term that involves doing all the things that we do normally, such as plan for things during the day, execute it, etc. And some problems sometimes with visual processing. But it's mostly memory, shall we say. Forgotten patient. So I found this quite interesting, because what it says here is, whilst the survivor may have very little memory of the cardiac event, the partner may struggle to deal with the fear, anxiety and guilt associated with the arrest, CPR provision, and subsequent care upon discharge of their loved one from hospital. And this often makes the caregiver a forgotten patient. So I'm trying never to forget the caregiver. What we know is that there are high levels of anxiety, anger, and confusion experienced by the caregiver. Don't particularly, caregiver, I prefer to talk about family member, friends, or relative rather than caregiver, because not really giving care sometimes, but it can go on for 12 months or even for longer. And so this is anonymous. So this is from actually a real patient I've seen. I think it summarizes actually what happens in the early stages as well. And I apologize if you recognize this. There's no name, so I hope I'm not causing any problems. But this is from a spouse that had performed CPR on the other spouse. And sorry I broke your ribs, but I saved your life. Which is it's a very, very effective way of dealing with the guilt as well, of having had to do something that has caused harm, but has obviously produced a very good outcome. I think that's a very, very effective way of processing the whole event. And I asked whether I could take a picture, and I wanted to present it to you as well. And there are very many of these examples, to be fair, when things go well. Obviously, so there's a lot of things that can go wrong, even psychologically. So it's not surprising that the Resuscitation Council recommends, as well, it's just a recommendation, it's not really mandatory, but screening for cognitive and emotional problems and referral where appropriate. But we don't really know whether this is happening or not. I mean, things are improving with regard to a registry of survivors. We'll get there. And but there's still a lack of an appropriate pathway. So we're not at the stage where there is a really clear pathway, which is what makes it more difficult. What we know, but we know very little, surprisingly. The little we know from a Swedish study that says that involvement of professional, either cardiologists, cardiac nurses or physiotherapists in follow-up is very limited. It's mostly cardiologists, understandably, but we do wonder, do you want anyone else to be involved? So that's the situation now. It varies all over the country and the countries, but generally a survivor in terms of follow-up input has access to a cardiologist, potentially a rehabilitation nurse, potentially a physiotherapist, seldom an occupational therapist, counselor or psychologist. Not quite sure there is a pathway for a family member. They may not need anything, but they might. And if they do, then is there something available? Oh, probably not. In terms of pathway, there are some attempts to offer a bit more of a structured pathway. So this is a pilot service from a Dutch rehabilitation center. So there is a cardiac and a neurological pathway, and they can be combined. So people can be looked at from a more holistic approach. But there's still the psychological side of things missing. The study that Tom mentioned earlier, the Stand Still and Move On, it was a very simple study in terms of delivery, so just some nurse-led treatment, but it was very effective. It's so far, I believe, probably the only RCT published about it, and ever so importantly, additional analysis suggesting a high probability of cost effectiveness, which is so important now. So if we do little, it's much better than doing nothing, and it can make a difference. I've only got 2 more slides, so I'm getting there. So I really think it's important that if psychological therapy is needed, it starts being delivered really at the stage of cardiac rehab. And that's why I'm so frustrated that it's not available to everyone, because that's a group event where people can feel sometimes a little bit more comfortable. That's not always the case, but it's very often the case. It provides an education around what's happened. It normalizes some of the experiences that you are going through, which can be quite scary if you don't know what they are. There is a physical activity under very controlled and safe situation, conditions. And there should be a psychological element too, and a general educational element about risk factor, healthy lifestyle changes, participation in physical activity, safe environment. If there is a psychologist, normally they deliver some sessions around anxiety management, stress management, because it's so easy to misunderstand, say, the symptoms of stress and anxiety with the symptoms of something going wrong with your heart. And if these get embedded into your brain, then you start thinking that you're having another heart attack when you're not, and you're just experiencing normal feelings. And for some people that's obvious, for other people that causes a lot of concerns, and it might actually stop them from engaging in life. Sometimes it's helpful to have psychology input just because people struggle to engage to start with in the cardiac rehab, because it's such a, it can be, they can feel worried about engaging in a group setting. And sometimes we work with people individually after the cardiac rehab and during as well, just to make sure that recovery happens in the best possible way. And we formulate people's problems. I'll get back to that in a second. Not everyone has access, though, to this type of psychological input during, before, and after. So many people can access counseling and private psychological therapies if if they're in the position of doing so after. So that's basically, in terms of psychological input, what is available now, but it's definitely very hit and miss. A practical example and then a wrap up. So we psychologists talk of formulation, doctors talk of diagnosis. There's different definitions of formulation, but basically it's something like looking at the bigger picture. We like the word biopsychosocial, so we look at your body, at the environment, and your psyche. And we try and figure out what's going on. So this is actually a real life example. I've just changed name, age, and a few other details, but this is how things can go sometimes. So we've got, let's say Jack, that is 55, has had cardiac arrest, a little bit of a complicated recovery. It's taken probably 3 weeks. There were some seizures when he woke on rewarming. Seizures were treated. Jack woke up, he was a bit confused, but got better, was discharged after 3.5 weeks. So now Jack is back home. He is having some fatigue, so he's really struggling to get up in the morning. Things get better, but Jack has also got a minor brain injury that was diagnosed in hospital, which is so unusual. And he does have some memory problems. And as soon as he got back home, he couldn't really cook, but he's back cooking now. So memory problems are there in the background. But what's really bothering Jack is the leg pain. So really, really bad pain in his leg, one more than the other. And he was worried that there might be a blockage in the legs and something might be happening. And this triggers a lot of anxieties that are cardiac in nature, because he sometimes experiences chest pain that seems to come and go without any reason. And then there's always this leg pain that really bothers him. So he can't do more than 50 meters. And there have been some investigations. They have finished, but there doesn't really seem to be anything that is treatable. So Jack is a laborer. He hasn't been back to work because he doesn't feel confident and he feels pain. So after a couple of months, he does have to apply for benefits, but that has a knock-on effect because he has always worked all of his life. And that's not the situation he wants to be in. So he feels a bit low. And this is obviously causing a strain on the relationship with the partner. It's just snappier than usual. Nothing dramatic, but things are not going particularly well. So then we've got the partner, who obviously has got their own issues. She was on the bus when Jack had cardiac arrest and she performed CPR. And she does think about it every now and then. It's not massive, but it does come back to her. She had to go from full-time to part-time, at least when Jack was in hospital and as soon as he was back home, just to help out. So that affected her as well. And she's got an elderly father who has got some caring needs. So that's what I mean by the bigger picture. If we break it down like that, first of all, we can ask Jack, what's the biggest problem? And Jack will tell me, oh, it's the leg pain, because if the leg was better, then I could go to work and things could be made better. So from a psychological perspective, obviously, I need to liaise with other members of the team because I need to know, is there anything that we can do to address this? Because this seems to be Jack's biggest issue. What I can do psychologically then is just to try to address these anxieties, because chances are that they are overblown, they are just too, they can be challenged, and he's just catastrophizing many things. Is memory a problem for Jack? Not now. Maybe it will be later, but now it's just in the background. I know it, but it stays in the background. So if I break it down like that, we can create together a plan of action, and we can try and move forward. There's no quick fix, but at least we've got something that we can work on. Future development, I think Tom has already covered this, expert group on recovery and follow-up of cardiac arrest survivors. We would like to have a more systematic approach that works ideally all over the world. I'm really keen to hear about your experience. So if you can fill out the survey, that would be really helpful. There is a disclaimer on page 3. So if you are happy for this data to be used for publication, please sign it. If you're not happy, please still fill out the questionnaire. Obviously, we will not include that data, but I will still be happy to know what you think should happen. But I should stress that even if you sign it, it's completely anonymous. We will take care of that. Yeah, that's my email address. If any of you wants to get in touch, has any question, or want to talk more in details about the specific experiences, I'm very happy to hear from you. And yeah, it might be that, as the NHS is now, commissioners are really interested in stories, in patient stories. So if somebody is willing to share the story, please do get in touch, and we can make it effective. We can use it to push our case forward. Thank you.